thank my teachers, students, my patients, and my and last but best, my family support throughout my life and in future. And let me proudly say that these slides, whatever I have prepared, is completely by myself. I have not used artificial intelligence. So, the take-home message. So, guys, don't use AI for PPT. Thank you. So, as Dr. Karmanan was highlighting, the core concept of pain production in the shoulder is just because of one simple reason. It is the faulty balance. I might sound a little odd. Is it so mechanical? Yes, it is mechanical. Because the stability of the shoulder is completely dependent on the muscular factors and not the bony factors similar to what you see in the hip. It is completely different. It is shoulder, it is one unit muscle. So muscular factors are many and it's viable for injuries. And that's the root cause of the pain. So we should understand if you think of pain, just immediately think of mechanics and nothing more.
0% sir.
What in shoulder pain? First, we need to know what is the prevalence. It is more in females. It is commonly observed in middle age, and it follows a cervical dysfunction. It can be because of osteoporosis, and it usually precipitates with psychological dysfunction rarely. And what is a disability does it lead to? It doesn't lead to much disability, but it puts your confidence to the floor. Because you can't do anything with your hand, you feel very bad for yourself. And especially in pediatrics, it's really doubling up the problem. It causes functional disability to a significant level. That's the most important thing what everybody has to understand. As I previously mentioned, the biomechanical cause for the pain is caused by the nociceptive nerve endings in the shoulder. See, we have mechanoreceptors and nociceptors in the shoulder. Both has a similar function. When the nociceptors are stimulated, it produces pain. When the mechanoreceptors are stimulated, you get a muscular activity to protect the joint from getting dislocated. As simple as this. So, our job is to see that there is a right balance between the mechanoreceptors and the nociceptors. It's not easy, but what happens if you don't do this? The individual develops a unique pattern, that is what you call it as a coping strategy. The patient develops his own way of lifting the shoulder. If you ask somebody to lift a painful shoulder, a partial press, you know what he will? He will bend and then he will lift the other side. You see, there is a composition of the girdle. He initiated abduction with bending forward and he lifted the shoulder. Okay, so this is the pattern. He's happy that he's able to do this. He's not worried about the shoulder girdle. But this is a compensatory mechanism. It develops, it gets into the individual and it goes on and on. You cannot prevent it, you cannot stop it, you cannot correct it. That's very, very difficult. You know, this pattern has to be unlearned. Unlearning is very difficult. What happened after Corona?
69.
Reels have become popular. Okay? You have become more dependent on YouTube learning than student classroom learning. So that's a problem. Very difficult. So, it causes significant dysfunction. It can be a personal care, a social care, or a family care. It can be anything from earning to relaxation. So as I previously mentioned, there are certain areas in the shoulder where you find the mechanoreceptors is directly proportional to the areas where you have the maximal stress. So if you could see, it is mostly to the superior and anterior and anterior-inferior part of the shoulder capsule. And if you could see the sites of pain, it is more anterior and inferior, anterior-inferior and partly superior. It can be capsule, it can be ligament, it can be muscular tendinous tendon. But gentlemen, you should understand the most sensitive part of the shoulder is your subacromial bursa. That is where you have the maximum nociceptors being. Whatever you do, it hurts. Because the shoulder gets increased upon the acromion, that causes severe pain. So this is the sites of pain to just have an idea of you. And the peripheral branches, you have got the complete peripheral branches of the subscapular and suprascapular. But suprascapular has the maximum innervation as a peripheral branch of the articular. It is articular branch. So it goes in line with the neural consciousness from top to bottom. I don't want to go into the depth of it, but what you need to understand here is if the pain remains for more than 3 months, you get pain in the region. When you have central sensitization, the present pain presentation pattern is completely different. And it is more in field. Right? Nobody. Except Dr. Naveen. Right? Nobody. Except Dr. Naveen. I know Naveen is the best in the shoulder. Anybody? What is the best technique for the shoulder? What causes pain? Which movement? To what intensity? At what frequency? Which part of the day? Which position of the shoulder? You try to educate the patient. That's the best modality, man. Before you could touch, as Dr. Karmanan was highlighting, a ruptured supraspinatus tendon, if you want to do job, your job is gone. Okay? So don't try to do provocative test in shoulder if the shoulder is irritable. That's a wonderful point, sir. That's wonderful. And that's the best model, very old model, as old as me, biopsychosocial model. You evaluate with history, get a working hypothesis based on the history, and go forward. Few years before, I was a crazy fan of all the special tests. What is the best article? An article from Cool Siddhartha. It has a sequence of tests, starting from Job to what extent. I'm not doing special tests nowadays. I believe that doesn't work at all. I'm not trying to flatter you, I'm just telling you practical experience. So, here is a wonderful thing, what all of us have, but we don't realize, we don't follow, we don't practice. Exercise-induced analgesia. This concept is a very old concept, but it has not reached its 40s. Nobody has tried to work on it, do research. I strongly recommend this fraternity to please invoke yourself in this direction and get some success. There are a lot of loopholes, there are a lot of directions, clinical implications. It really works on so many systems. I don't want to get into the depth of it, I don't have the time. It starts from central, that's the cortex, to your peripheral spinal cord, your peripheral level. It has both opioids and non-opioids system, which works on the analysis. Okay, sir, you say this all, but what intensity? You just do 30% of your maximum voluntary contraction for about 3 minutes. This is research. I'm not asking you to hold an isometric contraction for 3 minutes. That is practically impossible. It is all research, observation which has been made. You do it to the patient's comfort level, whatever you can, and he can understand. And it can be either isometric, it can be aerobics, it can be resistance. It has got significant hypoalgesic effects. So if you carefully give these based on the patient's individual capacity, it's highly subjective. There is no data or evidence which supports saying that you have to give this much to this person. There is no evidence. So you can boldly go ahead and just see the individual capacity and prescribe your own level. And I will be very happy if you youngsters go ahead and do research and identify for this rotator cuff tear and this individual, this type of exercise for this intensity can be done. That's a wonderful breakthrough. That's science. So what is the advantage of EAA? It is self-administered, non-pharmacological, it's easy, and it improves adherence. What happens when somebody is not able to lift the shoulder and you ask him to do 10 times of this? He won't come back to you. 1-star review, not 5-star. So you have to improve the adherence. Let us get into that. Anybody? Any more here? Okay, now just to gather the crowd, I'm going to talk about the most primitive exercise, that is the pendular exercise. Okay? How many of you here don't practice pendular exercise? Very bad, sir. Anybody else who don't practice? Very, very bad. There is so many hands are coming up. I am literally depressed, man. You know why? Because it's the most simplest. It is starting YouTube. Yes, sir. You teach me pendular exercise, please. Come. No, he's a model. Yeah, you're right. Teach me. You teach me. Bend forward. And leg front. Which leg? Both legs, just like that. Swing your body. Should I move the shoulder or the body? Why I should not move this? It's a voluntary contraction. What that means? Okay, I should move that body. Do you agree with, what's your name? Do you agree with Riyaz? You should move the shoulder or the body? Anybody? Shoulder, huh? How many of you shoulder? Ah, you guys are with me. How many of you have body? Ah, only very least. Ah, yeah. How many of you have both? See, pendular exercise nowadays it has been being taught in different ways. With weights, without weights, diagonally, rotatory, anti-clockwise,